Good morning, my dear professors and colleagues, dear Mr. Chairman. First of all, I'd like to thank Professor Dr. Sherif Megawer for his kind invitation. It's really a pleasure and an honor to share in this important scientific meeting. So my presentation today will be about the chronic rejection in liver transplantation. In the coming few minutes, I'll be addressing some definitions, the timing of chronic rejection, its incidence, pathogenesis, diagnosis, and how to treat it. So few definitions or few things that we all know. Rejection may be hyperacute, which occurs minutes or hours after transplantation, and could be an antibody-mediated agent cause. And acute rejection, which occurs days to weeks, and chronic rejection, which is mostly, by definition, occurs after months or years. Furthermore, we can classify acute rejection into hyperacute, as I said, and late onset acute rejection, which could be reversible. However, in chronic rejection, there's an early chronic rejection and late also as an acute, but the late is something what we really are afraid of and is somewhat irreversible. So we all know that the transplantation outcomes have significantly increased or significantly improved because of the improvement in the immunosuppression regimen and surgical techniques. However, chronic rejection is a slow, progressive process that may ultimately cause graft dysfunction and loss. It's an irreversible with a poor prognosis process, which could occur in any solid organ transplant. It must be differentiated from recurrence of the primary disease, and we all know that its prevention and treatment is still difficult. So what about its incidence? It can begin within weeks to months after transplantation. By definition, it's called chronic. However, it can occur at any time. Chronic and acute can occur within the same graft at the same time. More common in solid organ transplant versus liver transplantation. So we can see that the numbers in the the lung transplant, heart transplant, kidney transplant are somewhat more than the liver, which occurs in 3, a maximum to 17 allografts. So it accounts for 5% of graft loss in the first 3 to 5 years, approximately 16% of mortality among these patients. It is decreasing nowadays in adults, coming to down to 2 to 5%, versus the pediatric population. It can reach up to 12%. Of course, the introduction of tacrolimus-based therapy has made it less and had better outcomes in transplant. However, the recurrence rate is as high as 90% after retransplantation. So, but this meta-analysis shows us that the usage of tacrolimus is more useful against graft loss at 1 year post-transplant versus cyclosporin with less events causing graft loss. Also, mortality is less when we are using a tacrolimus-based immunosuppression rather than a cyclosporin-based regimen. So what about the pathogenesis? It's somewhat not well characterized. However, it's multifactorial things have been proposed: vascular, ischemia, antibodies, and cell-mediated pathways. It's rather not very clear. It evolves from severe or persistent acute cellular rejection and potentially leads to irreversible bile duct loss and or vascular injury. The hallmark diagnosis is ductopenia, which is loss of small bile ducts, and obliterative vasculopathy. In the allograft, ductopenia is caused by ischemia, as we said, and destruction of the the cells by an immune-mediated pathway. There are several risk factors which can lead or can occur in the patient leading to chronic rejection: underlying liver disease and autoimmune etiology, CMV infection, low levels or non-compliance to immunosuppression, HLA donor-recipient matching, positive lymphocyte cross-match, recipient age, donor-recipient ethnic origin, male donor into a female recipient, number and severity of acute rejection episodes, multiple ones, higher cold ischemia time, in living donor versus the deceased donor, and retransplantation for chronic rejection. In the pediatric population, there are certain risk factors as well. The race, the recipient race, the graft type, the presence of autoimmune disease, number of acute cellular episodes, the occurrence of post-transplantation lymphoproliferative disease causing the stoppage of immunosuppression for longer periods, and the presence of ductopenia, as I said, is associated with poor prognosis. However, we cannot set a prognostic factors for the evolution or reversibility of chronic rejection in this population. So what about the timing? Although chronic rejection is chronic by definition, it can occur in months to years after transplantation. No time limit, but exceptions usually occurs, and it can occur in the first 12 months post-transplant. What about the clinical features and diagnosis? First of all, it must be differentiated from late onset acute cellular rejection, which occurs 3 to 6 months post-transplant at time of cessation of higher immunosuppression usage. The incidence of this late cellular rejection could reach 40% and could lead to graft failure and chronic rejection. The more advances in immunosuppression regimen, as I said in the beginning, have laid more decreased in in the incidence of chronic rejection. As we said, that the low tacrolimus level preceded late onset acute cellular rejection, poor survival, and ductopenia and mortality. Clinical is often can be asymptomatic, non-specific, normal to near normal biochemical test in some patients. However, it should be highly considered in patients with liver biochemistry. If liver biochemistry deteriorated post-transplant, it can occur in a progressive jaundice, progressive cholestatic liver disease, graft dysfunction, and graft loss. Diagnosis requires histological confirmation. Liver biopsy is mandatory to diagnose chronic rejection, and it could be repeated also if biochemical response are not achieved or if I suspect other etiology. The histopathological diagnosis in advanced chronic rejection is characterized by loss of bile ducts in more than 50% of the portal tracts, or the presence of foam cell obliterative arthropathy. Preliminary findings may be the loss of less than 50%. However, the minimal diagnostic criteria can be the bile duct loss of more than 50% of portal tract, as I said, or bile duct atrophy and pyknosis of majority of bile ducts, and the presence of vascular injury. This is a more detailed description of the histopathological diagnosis, either early chronic rejection or late chronic rejection, considering the small bile ducts, the large ones, the hepatic arterioles, the hepatic venules, and the hepatic artery branches. So when we come to rejection, according to the Banff working group, they classified the allograft rejection into cell-mediated rejection and antibody-mediated rejection. The cell-mediated rejection, what we call the acute cellular rejection, which is more common, and the antibody-mediated rejection, which is what we called before the hemolytic rejection, which is a rare incident, a rare thing to occur. And I think Professor Dr. Al-Ainy will give us a brief or a detailed presentation about this issue. Both the acute types can progress to chronic form. So according to the ILET consent statement on immunosuppression in liver transplant recipients, acute cellular rejection may be early or late. Liver biopsy is mandatory, and it has been treated with steroids if mild, increase in the immunosuppression, pulse steroid if it's moderate to severe, or antibody depleting therapy in steroid-resistant cases or severe cases. What about the chronic cellular rejection, the chronic cell-mediated T-cell-mediated rejection? It is suspected in patients with prior history of chronic rejection, cell-mediated or acute, I mean, leading to progressive cholestasis, which is not responsive to immunosuppression, should be diagnosed by liver biopsy, as I said. Cyclosporin should be shifted to tacrolimus, and the treatment is somewhat difficult. What about the antibody-mediated rejection? It can lead into hyperacute rejection, acute and chronic. So it's really a big dilemma. However, From this graph, we can see that there are what we call the two-hit mechanisms. Any humoral alloimmunity could not lead to chronic rejection except there is an extra insult leading to this. So the presence of alloimmunity or the donor-specific antibodies per se does not lead to chronic rejection alone. And this could be seen by some points that I will now say, that we have the donor-specific antibodies in 13 up to 17 in transplant recipients, and chronic rejection does not happen in these patients. Not all recipients with donor-specific antigen develop graft injury. 8% of recipients develop de novo antigens after 1 year. And we can find that clinically stable recipients with circulating antigens have normal biopsies. This donor-specific antigen does not correlate with the increase in inflammation and fibrosis, even with complete withdrawal of immunosuppression. So we can say that the antibody-mediated or the humoral or alloimmunity or the presence of donor-specific antigens does not lead to chronic rejection alone. Back to antibody-mediated rejection, it could be an acute thing, which is somewhat rare, as I said. It could be diagnosed by liver biopsy, and the treatment included the steroids and the plasmapheresis or anti-B cells. What about the chronic antibody-mediated rejection? It's more common, but has no typical clinical or biochemical presentation. Vascular inflammation, interface hepatitis, interface activity, and fibrosis occurs. The complement deposition is somewhat low in liver transplant. It's difficult to diagnose, and the treatment strategy is not defined till now. So, the Banff update in 2016 have set some probable diagnosis for chronic antibody-mediated rejection, which is unexplained or at least mild or mononuclear portal inflammation and interface activity, at least moderate portal, periportal sinusoidal or perivenular fibrosis, the presence of complement fixation more than 10% of the portal tract, recent circulating HLA donor-specific antigen within 3 months of the biopsy, and exclusion of any other insult. However, the possible is the same with minimal or absent complement deposition. So we should also score the fibrosis in these patients. Fibrosis depends on scoring the fibrosis in the portal and preportal areas from 0 to 3, in the sinusoidal and subsinusoidal part, and perivenular according to a semi-quantitative scale from 0 to 3, ranging from none to bridging fibrosis. What about the treatment of chronic rejection liver transplantation? Either escalation of the immunosuppression regimen or the retransplantation. The risk factor for non-recovery include the donor age, higher total bilirubin and AST values, more extensive bile duct loss, small arteriolar loss, and the presence of foam cell clusters. So there are 2 regimens for the escalations of the immunosuppression. Either we convert from cyclosporin to sacrolimus, or we add on mTOR inhibitors. So this graph, the one on the left, shows us that the survival has increased and the response rate is 70% by addition of the cyclosporin or the conversion from cyclosporin to tacrolimus. The other graph shows us that the survival reached up to 80% when we shifted from the graft and the patient survival from cyclosporin to tacrolimus. Also, this figure shows us that the response rate after the shift from tacrolimus is 70% in chronic rejection. And they considered that the bilirubin level, if it's less than 10 mg%, the response will be more, and the graft survival and the patient survival will be more. Also, the shift from tacrolimus to tacrolimus was associated with more graft survival or prolonged graft and patient survival if the shift has been done after 90 days post-transplant. What about addition of mTOR? The addition of mTOR has been associated with increase also in graft survival and improvement in the liver functions, as we see in this graph. First, at the beginning, there was impairment of the AST and ALT and the bilirubin, even the occurrence of acute renal failure. However, with the addition of rapamycin, there were complete normalization of bilirubin and liver functions. In this study, including 2 pediatric patients who had done living donor liver transplantation, the addition of rapamycin or the addition of mTOR have been associated with the normalization of liver function, the bilirubin. However, there were no progression of fibrosis in these 2 patients. And this table also shows a lot of results, studies that have been included, the incidence of chronic rejection. As we see, it's more in the pediatric population, as I said in the beginning, up to 9% in the first study, this one. And it could be also occurring in the living donor liver transplantation, where we considered that patients who have done unrelated donor or include unrelated donors, the chronic rejection is more than these who had the related donors. In conclusion, while early acute cellular rejection does not affect graft survival, late cellular rejection is associated with inferior graft survival versus early and may evolve into chronic rejection. Chronic rejection presents as graft dysfunction, and liver biopsy is definitely needed for diagnosis. Earlier diagnosis and alteration of the immune suppression regimen can sometimes salvage the graft. Non-response has high mortality in absence of retransplantation. Although treatment regimens are needed, prevention is preferable, and the minimum includes medication adherence and monitoring of our patients. Thank you.